Next topic is the keynote address from our side, and it's by Dr. Nitin VERMA sir. He will be going to give us how we maximize the impact of ISMICS cataract surgery outcome on the global stage. Means we are already a global stage, and our founder chairman Sahu sir always said that it is the gift of word from the India. So sir is telling us and echo his own statements. Sir, please.
Thank you. Thank you very much. Look, I'm speaking to the converted, so please bear with me. Cataract still remains to be a big problem in the context of the fact that over 1 billion people live with vision loss, and this number is increasing. 100 million need cataract surgery. We won't worry about the rest. And also, if we look at the number of people increasing, the number of cataracts are increasing, and while our capacity is not increasing at the same rate. So look, there the gap is increasing. So given the fact that 90% of cataract blind live in emerging economies, where are we headed? I mean, we're obviously losing the battle against cataracts. That's because for a long time we've been working on number of cataract surgeries done rather than the outcome, the quality of what we've been able to achieve. Looking at something like the effective cataract surgical coverage, which really tells us what we've been able to achieve in terms of outcomes, I think that's what we should focus on. And really what we find is that there's a big gap based on the socioeconomic status. So if we go on a little further, cataract surgery is one of the oldest surgeries known, and I've had the good fortune of working my way from intracapsular all the way to where things are right now. And one can see that there have been moments where, when extracapsular surgery came in and so on, so things kept moving. And we still have this great debate about phaco versus 6. And I think it's time to put that to rest, because all the data that we have right now very clearly shows that both surgeries can produce equally good results. So without going into all the data, including the review by the Cochrane review, which basically shows that, a little bit to the left, little bit to the right, but basically both these surgeries are the same. But that's where the comparison stops. And the difference starts now. For example, the cost of a small incision cataract surgery versus phaco, there's a great difference. And in that, 6 clearly wins. Also, when we look at climate change, which is a great problem, and the healthcare industry is responsible for a large amount of greenhouse gas emissions, ophthalmology needs to start working on decarbonizing. In the Royal Australian New Zealand College of Ophthalmologists, we are serious about it. If you look at the number of cases done per day, you produce 1 bag per case of one surgeon, but in a year, this is what waste looks like. So if you're doing 10 million surgeries a year in cataract, can you imagine the waste that we are producing? We've footprinted cataract surgery and looked at the carbon dioxide equivalent emission and find that the amount of surgery of carbon dioxide emission in phacoemulsification is the same as burning 67 liters of petrol. And the major thing is the transport of all these consumables, transport of all the disposables. Now, if we look at the way India does things, I think there's a lot to learn. Why is it so difficult for the rest of the world to go that way? The College of Ophthalmologists in Australia and New Zealand is taking it seriously and has produced guidelines on how to reduce waste in cataract surgery, intravitreal injections, and also suggested a sustainable cataract pack. I won't go into disinfecting tonometer tips, but that's another story. And I think that in Australia, we are really working, trying to produce standards that are acceptable all over the country so that we can, do things. But leave that alone. Let's look at the rest of the world. And our, mass cataract surgery is quite good. And I'm so impressed with the way that small incision cataract surgery is done fast, quick, safe, good results. And backed up by vitreoretinal surgery. So I've done this in Papua New Guinea. You can see this surgery can be done. That's how patients come and go. We've done that in East Timor. So wherever we go, we find that this procedure works. In India, where you do 8.4 million cataract surgeries a year, 55% of them are manual small incision surgery without sutures. But you know what's happening also, if you look at the RAB study, you'll see that complications of cataract surgery, now this is a little tricky business, are listed, it's listed as a cause for visual impairment. Now, you'd say, well, look, how can that be possible? It's possible because you're looking at comorbidities, you're looking at lots of uncorrected refractive error and so on. So if you try and see what's happening for cataract surgery in Australia, it's almost like a refractive surgery. But still the main cause for poor results remain concomitant disease and residual refractive error. So, you know, it's important that we address this, doesn't matter where you are. And also to answer the question that is it worthwhile for surgeons who routinely perform phacoemulsification to learn six? I think the answer is yes. And for that, I would say thank you very much to the International Society for Manual Small Incision Cataract Surgery for opening a branch in Australia and New Zealand. The president is sitting right here in the middle, Vignesh Raja. But look, we have taken things forward there. We run courses, we run lectures. We had younger ophthalmologists wanting to come and learn six. And not only that, we've extended our outreach to the Pacific and have really worked on improving outcomes of cataract surgery as a specific project. We will continue that this year. Here are some photographs from a workshop in Fiji, and Parikshit came for that. He impressed them so much they want to open a chapter in the Pacific also. But that's how it did, and I tell you, it was very well sort of received. And I think some of the things that really come up, the important part is not the surgery. The important part is the journey of the cataract patient, from case selection to management of complications. And that's what we should be looking at. Get better biometry, better management of comorbidity. You know, better surgery is fine, we always concentrate, but better management of complications, and of course, auditing. I think it's time when we need to stop this debate or this quarrel, because in the end, we'll find that who suffers? It's going to be the patient. So, again, to the question, are we winning the war against cataract surgery at a global level? The answer is no. And now with the changes that have come in the world, with the way help is given and assistance is given to countries, we really need to think, because this is a time for us to recalibrate the way we do things. It's not going to be business as usual anymore. And I think as we move forward, we need to focus on good vision and try and achieve the Sustainable Development Goals of the United Nations, none of which will be possible without good vision. So I think that's really where we need to go. We need to look at the whole journey. We need to look at the outcomes. We need to look at the carbon footprinting and the sustainability of what we do. And for that, I would commend the society for working in that. So thank you so much for your attention.